Okay, so let's get started. So today's topic is spondylolysis, and the way this works is if you have any questions or comments or whatever, just interrupt, because that's the whole point of learning from each other, you know. So I'm just going to go over spondylolysis, and that's it. So it's clouded with all these terms, and I never use these terms anymore, other than when I dictate the final diagnosis, because they get mixed up. So spondylo, because I'm Greek, everything is, and Nick, you're Greek too, so we have to take pride in our heritage. Yep. So spondylo means Greek, so all these words have to, spondylo means spine, so all these words have to do with the spine. So lysis means destruction, listhesis means sliding, spondylosis just means the degeneration. Isthmus is where the spondylolysis occurs, and the pars interarticularis just means place. Interarticularis means between the two joints. So lysis just means destruction. So Karen, can you open the light for 1 second, please? So I'm going to draw a spondylolysis for everybody. Hold on. So it's the place between the two joints. So I'm drawing a spondylolysis between the two joints. So here's one facet, and the fracture. So that's exactly. So I think it's. Can you turn the lights off again? So I thought it's important for everybody to see where spondylolysis is. It's the place between the two joints. So lysis means destruction. So this area is decimated. So the spondylolysis. Listhesis. Spondylolisthesis means sliding. So I never use the term spondylolisthesis with patients because it took me 10 years to finally understand all these terms well. And then how is a human being going to ever remember these words? So I just say your bones are sliding. And isthmus, this is the isthmus in Corinthos. It separates the northern half of Greece with the southern half of Greece. And it's a tiny cut. So isthmus, I can't say it, is a narrow body that connects two bigger bodies. So if you can remember, isthmus connects this sea to the Ionian Sea with the Aegean Sea, and it's a small, narrow body. So you can see where the pars is, it's a small, narrow body of the posterior elements of the spine. So that's the isthmus. Hey, Rob. So it's a fracture of the isthmus, which is in the pars interarticularis. The isthmus and the pars interarticularis are the same thing, and you get a fracture there. So does anybody have any questions about nomenclature? Okay. So this is I used to work in D.C., and this is in the natural history exhibit in D.C. in the osteology exhibit, and I go there a lot with my kids. And when I used to work at GW 15 years ago, the curator told me the story that this skeleton used to be a radiologist in the D.C. area, and when he died, he decided to leave his body to science. So they put him in the exhibit, and he's very upright, just like all radiologists are. Stands upright, very proud person, very smart. He's a real human being. Now, he had a best friend that was an orthopedic surgeon, and when he found out that the radiologist donated his body, he was furious. So he put in his will, I'm going to donate my body too. So when he died, the Smithsonian put him right next to his best friend here, the radiologist. And then the pain management doctor got into the mix, and then physical therapist, the chiropractor here, they all got into the mix. So, but what's important in this is that if you look at the spine, it's only the human spine that stands upright. There's no other animal that ambulates on 2 feet with respect to the lumbar spine consistently. So all other animals usually use all fours. And the other thing is, what's interesting is almost all spines are kyphotic in the lumbar spine. And this is a raccoon. And if you go, this is an amazing exhibit. Has anybody been there and taken? You should go. If you take your kids, see if you can have somebody else watch the kids for an hour to look at this exhibit. It's amazing, and all to look at the bony elements of the other animals because they're so similar. It's incredible, and every other animal has lordosis, and this is my personal theory why spondylolysis happens. All the other animals have, kyphosis in the lumbar spine, and we're the only one that has lordosis, so that we can stand upright. And I think because of that, there's an extension force across the L5 vertebra, and because of that, we're at risk for spondylolysis. So, this is the fracture, spondylolysis, fracture of the pars interarticularis. Now, this is me trying to put my kids to sleep, and my daughter grabs my iPhone and takes a picture. You can see I'm angry, but this is my daughter. She's 7. So the reason why I put this slide is that you remember that if you go to her class at the age of 7, 1 in 20 kids has a pars fracture. So if you walked into her class, that's the last thing that would be on your mind. You would think there's no way. If someone told you that, there's no way that that's true, but it is. So pars fractures occurs in the population in a 5 to 6% rate at the age of 6 or 7. Which, don't you guys find that amazing? I mean, it tells you something, and it has to do with we're human beings. There's no other animal that has spondylolysis or fractures of the pars. We're the only animal that gets it. Also, no fetus, no baby has ever been born with spondylolysis. The earliest, I think, is a couple months, but we're not born with this. So this is a result of us being upright as an animal. The other thing is that no human being that is non-ambulatory has ever been found to have spondylolysis of a pars fracture. So it doesn't happen unless you're upright. So that tells you something why this happens. It's the extension force when you're standing. And it's very common, so it's 1 out of 20 people. So if you see somebody with spondylolysis, you say they have a fracture, they're very, very, very worried, especially moms. And you say, look, 1 in 20 kids has this. And most people don't have any problems at all. Now, there was also, that 5% is from the United States where they studied, I think, first graders prospectively, which is amazing. I mean, how can you imagine trying to tell a class of parents that we're going to take x-rays of all your children for a prospective study? It's very difficult. It was done in the early 70s. That same study has been repeated in China, and it was found that with a CAT scan, a CT scan, and that's impossible to do in the United States, do CAT scans on kids. But in that study in China, there was a 10% rate of spondylolysis. So it's probably even higher than 5%. So do you guys have any questions about that? So I think those statistics are very, very interesting. Yeah.
Is it not that initially when I studied still, I remember that it was said that it is failure of these to unite these
failure formation of two elements? I don't think so. I think it's more has to do with the extension force across the L5 body. So it's not really a failure like Osteiod. There's a seat right here, Doug. It's more of the fact that you extend at that level, especially at L5, L4, L5, S1, and because of that extension force, it causes a fracture, a stress fracture. So this is just shows you again the stress fracture happens at the pars area, and they can separate. It literally can separate the front of your spine, the anterior portion of the spine, from the back of your spine, and the whole thing can slide forwards. The whole spine is sliding forwards. So this shows you can have a fracture here, spondylolysis again, and that separates the front of the spine from the back of the spine and the pelvis, and the whole spine can float forwards. So that's called spondylolisthesis, but we're not going over that today. Today we're just going to talk about isthmus fractures or pars fractures, but that's going to be next month. So there's just a couple things to understand in a human being is there's a gravity line. The head should line up with C7, should line up just above T12, should line up with the middle of the sacrum, should line up with the pelvis and hips. The L3 vertebral body should be parallel in general. And you can see how much lordosis we have down here. It's very unnatural compared to all the other animals that we have this lordosis. But that lordosis allowed us to stand upright and use our hands so we can become, orthopedic surgeons. And the lordosis is tremendous at L4, L5. It's 23 degrees and 24 degrees. So most of the lordosis, and then it goes, L3, L4 goes to 13, L2, L3 goes to 7. So most of the lordosis of the lumbar spine is in the bottom 2 discs. And it's because of this lordosis, this tremendous lordosis that we have, it puts a big extension force on the bottom portion of the spine, on the most inferior portion of the spine. And I think that's what causes the pars fractures. But I mean, I may be wrong. This is my personal theory. There's also activities that cause pars fractures. Has anybody seen any patients with pars fractures? Doug? Can you recall kids?
Yeah, football players.
Football players. So offensive linemen. So you can see that force that's going across his body. That puts a tremendous lordosis force across his lumbar spine. Offensive linemen get it. You can see the extension in a gymnast. That puts a lot of force across L5. Divers, they put a tremendous amount of extension on the lumbar spine. They can get it. Wrestlers, because they very commonly forcefully extend their spine to do a souffle move or to stand up. Like when you have anybody wrestle? Has anybody here wrestlers? You know, the main thing is when you're on bottom, you got to stand up. So stand up, stand up. I used to be a coach. This is my son, and this is one of our matches. And you stand up with explosion, and that extension force can cause the stress reaction and pars fracture, and also rowers. I think one study was like up to 47% of a study where they studied divers had spondylolysis. And then it's also there's a hereditary factor too. This is not Pac-Man, but a pie chart which shows you 25%. So if you have a first-degree relative that has a pars fracture, there's a 25% chance that you will have it as well. So there is some type of hereditary factor going on, so it's always a mix. So if you see a child with a pars fracture, the parent is very upset, and they're going to say, what does this mean for my child? The chances are nothing's going to happen. But around 4%, a very small number, do progress where the bones start to slide, the spondylolisthesis. So this is a child with an L5 pars fracture, and this child has started to progress with spondylolisthesis. You can see the back. What do you? How would you describe this, Nick?
I would describe that we grade them grade 1 spondylolisthesis, which is less than 25% anterior slippage or spondylolisthesis of the vertebrae with respect to each other, with, of course, the spondylolysis.
Okay, and would you say comment there's a possible lucency, or what would you say?
Here I would, yeah.
Yeah. So, and then the other thing is, as orthopedic surgeons, we need to have standing films because it usually gets worse when patients stand from the gravity forces. So they usually present. Doug, how do you think spondylolysis patients present to you?
3 months of back pain.
3 months of back. So it's back pain that doesn't get better.
Right.
After ibuprofen.
Right. Went and had a normal X-ray. Still not better. Hurts when they do something like military bench press or something.
Okay. And then on physical exam, most of these children have hamstring tightness. So this is the popliteal angle, and most kids should be about 30. Most kids go up to 90, so the leg is totally straight. Kids are really flexible, but within 30 is probably about normal. But if they're tight, if their hamstrings are tight, that may tell you that something's going on in the lumbar spine. So if you guys remember, these are the hamstrings in the back. The medial hamstrings, semimembranosus, semitendinosus, are usually like L5, maybe L4. And the lateral hamstrings, which are the biceps, are S1. So those are the nerve roots in the bottom of the lumbar spine that have a problem with spondylolisthesis. So often these children have hamstring tightness as their only presenting complaint, and back pain. So, Dr. Lomas, since you're a radiologist, how would you describe this image?
Oh, well, this is the infamous Scotty dog appearance. So, as you can see just from looking at the model, just conventional views, AP and lateral, can be hard to see the pars. So when we oblique the patient, you're looking more down the barrel on the pars. And so I would say, for one thing, that it's underpenetrated, unfortunately. Or just the way it's
okay,
the bottom line is, you can see the Scotty dog you have. There's the head of the dog. You can see the ear poking up, which is the inferior articulating facet, or superior articulating facet of that
This is the ear and the
And-
supraarticular facet of L5,
And then
right?
the pars is the neck of the dog, and so you're looking for the defect in the neck. We're correlating to where that red collar is, and so that's where we're trying to find a pars defect.
And would you say that the pars area is the same density as L4?
It's more sclerotic on this one, whether or
Okay.
not that's technical, but yeah.
Okay.
I don't see a definite lysis.
Okay. You don't
here,
think this
so-
is lysis?
I don't know.
Not
It's
sure.
a little,
Okay.
you know,
Okay. And
this
it.
one's, it could be the way it was, you know, photographed.
Okay. And Doug, what would you? Why? Like, we always like to have stories in orthopedics. Why would you say, if this is sclerotic, why would you say it's sclerotic?
It's a fracture that's trying to heal and breaking and trying to heal and breaking and trying to heal.
Stress.
So it's like a stress fracture. Okay. So so here's another view of the side. What do you think of this, Dr.
I'd
Lomas?
call that one. So that looks like that is a pars defect, and then with slippage, spondylolisthesis.
Okay. And this is you have to trust me. This is the same exact patient on the MRI at L5. Would you say that there's a pars fracture there?
Well, just on the one image, possibly on the left, it looks like there may be a little hypertrophy, a little sclerosis. So, you know, again, looking at multiple images helps. But
Let's
it looks
say
asymmetric.
you make a call here. So
On one side.
it's difficult to say, right?
I'd say based on the plain film, it looks positive.
Yeah. So it just goes to show you that the X-ray is a lot more obvious than the MRI scan. Would you say?
Well, you know, it depends on a lot of factors. One, the degree of lordosis. In some patients, it just lines up beautifully in the axial plane, and in some, it is very difficult on MR to pick it up.
Especially
axially.
if the gantry's off.
It all depends on how it's angled.
Yeah.
So that's MR can be tough. It can be easy to overlook. It's the same thing. Plain film can be tough, even on obliques. If they have very lordotic spine, even on oblique views, you may not get that good look at the pars. I think still taking all comers, CT is the easiest to see it with multiplanar reconstructions. In my opinion, that's the best study to definitely pick it up. You have the best chance of reconstructing it to pick up a pars defect. But the radiation issue is which you have to
right.
think about as well.
There's adoration. So what do you so what do you think of this, Dr. Lomas?
So you can see marrow edema within about the pars interarticularis. So there's definitely stress reaction, stress edema there, and then you can see a small little low signal cleft right through the pars. So there's definitely an injury of the pars. So either a stress fracture, no definite separation at this point.
Okay, and that's something that Adam taught me, that pedicle edema is spondylolysis, sort of, until proven otherwise. I didn't realize that. So here's a bone scan. What would you say of that?
So SPECT, you can see.
What's
on the right-
SPECT? What's SPECT for everybody?
Single proton emission computer tomography. It's basically a bone scan where we do tomographic images. So we're
Okay.
able to take axial images through the specific level. So rather than just planar imaging of the entire spine, you're able to get tomographic images like this. So it looks like basically the same plane as a CT. And so we're slicing through that level, and you can see the intense activity showing osteoblastic activity at that level of at the pars.
And what does that mean?
That's bone repair, basically. That's bone healing. So this would be compatible with pars, spondylolysis at this level.
Okay.
Hey, Spiro, how
Yeah.
about a STIR MRI to find a pars fracture?
Well, we have an expert here. What do you think?
I mean, same thing. STIR, very sensitive at picking up marrow edema.
Okay.
So
We do wanna-
just like on the prior image, it's even more sensitive. It's suppressing signal.
Is this a stir, fat suppression stir?
That's not a STIR.
That's not a stir.
Yeah, that looks like it's got to be a T2. You can see a little hyperintensity in the foramina, so that's going to be CSF. So I believe it's a T2, maybe a proton, one of the two.
Okay.
But the bottom line is it's showing edema, but STIR very sensitive.
So if you're concerned about a child and subjecting them to the radiation, you could opt for the STIR.
Yeah.
What do you do, Doug? What do you do to confirm a diagnosis if you have a child and you suspect a pars fracture? Do you just not do a test? Do you do a test? How do you handle it?
If the X-rays are normal, then I'd probably treat them symptomatically. You know, have them come back in a month or so and sort of follow them. If I think if we
Let's say if the mother's really worried and she wants to make sure she wants a diagnosis. Mother's worried it's 3 or 4 months.
well, I think the SPECT is the most sensitive in my hand, but I
So you
usually
send them for children for bone scans?
I send kids just for maybe a bone scan.
Bone scan?
Yeah, I'm not so big on SPECT for a kid if it's,
What is the SPECT imaging more radiation?
it's a CT. It's a
SPECT,
CT, a bone scan, you don't get the CT.
SPECT's.
You put them in
it's
the
a bone
CT scanner?
Yeah, it's a bone
Wait a minute,
scan.
a SPECT scanner, do you put them in the CT?
No, it's on a nuclear medicine camera.
Yeah, so you don't get extra radiation.
No,
It's-
the CT of it is for CT. They get a bone scan injection, and then they go in the CT scan.
No, it's
That's
done.
how you
No,
get
no,
it.
they don't.
It's not a nuclear medicine camera. It's not done.
Nick's a radiologist.
That's not done on
He's a
a.
radiologist.
It's not done on a
My kid
CT
beats him on the
scanner.
swim team. But I
Yeah.
think it is because that's how you get the 3D.
Wait, you
thing.
guys swim together too?
It's the type of camera. It's a nuclear medicine camera. It's not done in a CT scanner.
It's not a
Take off my
CAT.
jacket
No,
and this one.
it's not done. It's a
Yeah.
the CT portion of it just means it's tomographic images, which
Right.
means slices, basically.
So they have what? They have like a donut in the bone scanner that
Exactly.
they go through and they get 3D slices,
exactly.
right?
Yeah, so it's still done in nuclear medicine. It's not a.
It's the same test, isn't it?
It is. It's the same radiopharmaceutical.
Radiation, right?
Right. So you're going to inject
So for me, it's a
technetium
free-
99M HDP, which is the agent. Same agent.
Right.
I believe it's the same dose. I don't do a lot of. I haven't done SPECT. I've done just planar imaging for the last 5 years.
Uh-huh.
But I think it's got to be the same dose.
Mm-hmm.
And but it's just a matter of how you post process the patient, how you image them. It's a different camera, and it gives you tomographic images. It takes longer. So that's one of the issues.
But for the
with-
child, it's the same dose. So I
It's the
figure
same
it's a
dose.
freebie for me. Might as well get the nice anatomical picture.
Right,
If-
and with these agents, the target organ is the bladder. So that's what's getting the most radiation when you give nuclear medicine bone scan. It's still low dose, but it's still radiation you're injecting into the patient. So there's, in kids, that's always something you've got to discuss. I mean, MR is the one test that is going to give none, but then you have the cost issue. So, again, I still think the most sensitive is this.
CAT scan.
In my opinion, it is. Because
So
now
what do you think
with-
of this CAT scan, Nick? So let's go over this. This is a 14-year-old club-level soccer player. This child, I don't know if you guys know what club-level sports are like, but this child goes to Chicago for a game. I mean, they're really, really into the sport. He's like a national-level soccer player here in Bel Air. And he had back pain. I told him just stop playing soccer, but that was like impossible for him. And finally we got an x-ray, we got an MRI scan, and finally I ordered a bone scan, which lit up at L4. And then the mother, I told her to know exactly for sure, definitely it's a CAT scan. Mother wanted the CAT scan. So what do you think of this CAT scan, Nick? This is a 15-year-old. When he first came, he was 14. Now he's 15. This is the date, and here's the CAT scan. What are your thoughts?
So it doesn't look so bad. So can he play?
We'll get in that in a second. Go ahead, Nick.
So you can see it's labeled for us. So L4 pars pars fracture, and looks. I just see some of this one's actually complete on the other image, and you can see mild sclerosis about it. So it looks like there was something going on chronically, bilateral. It looks like this. It's got bilateral injuries.
Okay. So if these pars fractures, if they develop callus, they can compress these roots. So if this is 4, this is the 4 root. It can hit the 4 root, and it sometimes can hit the 5 root as it goes across. It's right in the same area. So here's the exiting root and the traversing root. These are important for us as surgeons because we have to know in our mind's eye where they are. So what would you do in this child, Doug? 14-year-old has an L4 pars fracture.
Brace him, do a little stretching, a little bit of
Okay.
therapy.
What kind of brace?
An off-the-shelf lumbar corset.
So just a lumbar corset like the guys at Lowe's wear.
Absolutely.
Okay. I gave him a molded plastic one, and I said the best thing to do is a thigh cuff, but he refused the thigh cuff. So he did the brace.
The other question, Spiro, is if he has a tight hamstring, does that exacerbate his lordosis?
But it shouldn't. It shouldn't.
Supposedly,
It shouldn't.
the reason for doing therapy, is to stretch out his hamstring, and is it a cause and effect that is tight because his nerve is inflamed?
It shouldn't.
Or once it's inflamed.
I don't think so because the hamstring is the ischium to the knee. It shouldn't. I guess it could, but I don't think it should. So this kid was put in a brace. Mom demanded another CAT scan. So what do you think here, Nick?
Don't see the fracture. Yes, sclerosis, so it looks like he's healed, at least that side that we're showing. And same thing there. You can see a little lucency on the left, but certainly improved.
So it got better in 7 months. And he went back to soccer, and he's 100% now.
I got better.
Hmm?
I got better.
So here this is what I put him in, an LSO. It was plastic thigh cuff, plastic, but to mobilize the L5S1 segment, you need a thigh cuff. But nobody will wear this thing. There's no way. The other one you can wear under your shirt, and the other reason why they get severe radiculopathy is it's right where the dorsal root ganglion is of the nerve root. So here's the pedicle, and you can see this is a very sensitive area. So these people with pars fractures, they get callus right here. I mean, I know because I have to remove it. And it's right in the inferior border of the pedicle. And it's a really bad place to get it because it compresses right on the dorsal root ganglion, which can be very painful. So, Megan, what would you do with a patient with spondylolysis, back pain, and hamstring tightness?
I would definitely initially, discuss with them the importance of repeated stretching during the day. Stretching one time is not going to do it, but usually I tell them to stretch two, 3 times every couple of hours their hamstrings. I work on their posture because most of the time it's posture related. I talk to them about body mechanics with carrying bags. If they're 14, they're carrying these heavy bags. They don't usually like backpacks, so you're putting them, equally weighting them, working on core stability.
How about you, Rob? Would you do anything differently?
Yeah, pretty similar protocol. Yeah.
Okay. So the other differential is the Osteiod osteoma. I mean, in this case, I think it's kind of obvious. How would you describe this, Nick?
There's a lesion within the pedicle on the left. It's centrally there's a sclerotic nidus surrounded by lucency and then marked bony sclerosis, and it looks characteristic for an osteoid osteoma.
So that's the other thing a child can get. Now, since I'm a surgeon, I always think of how can we surgically fix this. But I can say I've never fixed one. I mean, I've just never had a patient that needed it. They either got better or they didn't want surgery. But there's 3 basic repairs. One is put a screw across it. So all of these repairs are, first you debride the whole non-union. Like all non-unions, you remove all the fibrous tissue, put iliac crest bone graft in there, and then repair it in 3 different ways. One is just put a screw across it, and that's called the Buck's direct screw. The other one is to wire it with a figure of 8, which just like you would do an olecranon, and then tighten it up. That's called the Scott wiring technique. And the last one is a pedicle screw with an infralaminar hook, which is probably the strongest way to do it and the least likely to fracture. Like these two, I would be worried that the implant would break if the fusion didn't take. And this is the Kakiuchi screw and hook technique. So there's a pedicle screw, and here's the fracture, and then there's a hook, and you compress between the two. Oops, and that should stabilize the fracture and help it to heal. And the other option is just fuse it. So the fracture's here, and you put a screw above, a screw below, and weld the bones together and fuse it. But if you do it in this manner, everything moves the same. So this disc moves, this disc moves. But if you fuse it, this disc never moves again. So in theory, this is better because the child still moves at all of his levels. But it's a rare surgery. So so any questions up to this point? We're almost done. This is like the last case about spondylolysis. So this is the last case. Maybe Dr. Dinkar will tell us how he would treat this patient. He's 61 years old. He's got right sciatica for several months, and he's seeking a third opinion. He's had 2 other opinions that they all said fuse the L5S1 segment. But he had a friend that he golfs with that I did a surgery on and said that it was outpatient and it did fine. You don't need a fusion. He's extremely healthy, 61 years old, married, he's a retired fireman, and he's an incredible golfer. He golfs like 6 hours a day. So what are your, so you're going to tell us how to treat it, but Dr. Lomas, what do you think of the films first?
So mild left curvature of the spine. I think the target here, L5-S1. He's got severe degenerative disc disease. He's got some facet osteoarthritis. He's got.
Why do you say he's got disc disease? Tell just so everybody else knows.
He's got disc space height loss. He's got some
it's
in-plate
really flat.
spondylosis, in-plate spurring.
Spurring here. Okay.
It does look like he has a pars defect, even though it's just a lateral view. He's got spondylolisthesis, slippage.
Maybe
Grade
here,
1.
here.
I estimate 4 or 5 millimeters.
It's hard to tell, but here's maybe the back of the sacrum right here.
Yeah.
So maybe a little bit. Okay. All right. And here's some flexion extension films, Dr. Lomas. Can you see them? I know they're poor technique. I'm sorry.
It's all right.
Sliding.
Looks to me about the same. I don't really think it shows much.
Okay, so you're going to
motion.
say in your report no instability, no significant motion.
Yeah.
Okay. Is this a very mobile spine, would you say, or is it a stiff spine? Like this is maximal flexion, this is maximal extension. I'm just curious, how would you describe it?
On the pars.
Like they don't go flat, right? So he maintains lordosis despite flexion. So it's kind of stiff, I would say.
I've never commented on it. If that's something, so I've never commented on that.
Okay.
But something to
something
think about.
as orthopedic surgeons,
Yeah.
we think differently. So that's in my thought.
It's good to know. Yeah.
So what do you think of the CAT scans and the MRIs, Dr. Lomas?
So again, CT beautifully shows the pars defect. And
The MRI.
MR.
Does that change? Can you see the pars defect here?
Yeah, there it is over there on the left. Yeah.
Okay.
So, I think doesn't really add much. I think from plain film otherwise.
Okay.
For the other levels, yeah.
Okay. So how about here? Why don't you comment on his axial cuts of his spine?
All right. So you've got them labeled there. 2, 3. So the bottom line is that at the level of the spondylolysis, you can see he's got.
Right here. Sorry about the quality.
Just trying to figure out which one's which here.
This
So,
is 5 right here, and this is 5 on the CAT scan. This is 5 on the MRI.
All right. So at least axially, you can see the pars defects bilaterally. And his spinal canal actually isn't significantly narrow. There's a little bit of lateral.
At L5.
Measurement. Right.
Okay.
And for the foramina, of course.
Here's a little. How about see that little osteophyte?
Sure, a little spur.
We're
Yep.
hitting the 5 root right there.
Yep.
And see the 5 root live right there. See the osteophyte.
Yeah, absolutely.
So and the fracture. But what do you think about the canal above in this case? Because Dr. Dinkor's got to treat this guy surgically. Would you say the canal's normal? Is this normal?
Looks okay at 1, and then as we progress more inferiorly, you can see progressive canal narrowing. And I guess is that 4, 5, that's 3. So
Was this now? Is this 3? This is 3 pedicle. This is 1 pedicle.
Mhm.
Is that a normal sized canal? Would you say?
it's narrowing. I mean, it
So
could be
it's
a combination of some foreshortened pedicles, could be congenital.
So congenitally small canal in this guy.
Right.
So what would you say? How would you describe 3, 4, 4, 5?
For there, I'd say he's got definitely moderate narrowing. He's got ligament of flava thickening. His pedicles are short. His disc looks mildly bulged. Laterals, sagittals help confirm that. But the bottom line is he's mildly narrow.
Actually, 4, 5 is not so bulging. 3, 4 is.
Yeah.
But it's probably more to do with the congenital or developmental spinal stenosis, right? This guy was born with a small tooth.
Yeah.
So how would you treat him, Dr. Dinkar? Fusion, L5S1 fusion, decompression?
Actually, I will treat with the decompression, fusion and stabilization.
Of L5S1. Okay. So he didn't want a fusion. So we spent a long time with it, and I just did this case, a decompression. So I just decompressed. I did hemilaminectomies at 4 and 5. And here's the pars fracture. And I can tell you that pars fracture was incredibly mobile. I mean, it was really moving. So I think the callus is going to build back up in this guy.
Yeah, I could see it on the flexion extension views. It looked like all his motion was going through the pars fracture.
Probably.
Yeah, he wasn't really slipping, but he
Probably.
And it almost looks like he has a joint on that.
He has pseudoarthrosis,
Flexion,
yeah. That's the definition.
So how do you, so in the
got
OR,
22,000 on the bottom of the charting, Spiro, was that the charge? On the bottom right there.
No, that's a dictation number for up Chesapeake. But I say you didn't
Actually,
dictate it,
there's
doctor. I was like, yeah, I did. 227811.
I see 6 digits.
No, this doesn't pay $2,000.
So when you say it's mobile, that when you're there, then you can. How do you tell?
Loose, obviously loose. So it's hard to say how many millimeters because we're under a microscope. But Eric, how would you describe how loose it is? Eric's my assistant.
Loose, probably
which is a lot in the spine because of the nerve root. I mean, there's not much space there. It's like 10 millimeters. So, Dr. Schneider, how would you have treated this patient with this canal and that history? What would you do?
I mean, I guess it depends on the patient's specific complaints.
Sciatica, L5 radiculopathy.
Okay, I mean, I guess I'd probably offer the guy a epidural steroid injection at L5S1 transferaminally and see if it can abate the symptoms just with that. It's unlikely that it's going to stay resolved with a steroid injection, but it would be worth a shot for palliating his symptoms.
Okay. Is it hard to put it in that space? I mean, it's kind of a deep, tight space. No.
No.
Do you curve your needle, or you just curve needle? Okay.
Do you have to go at that level, or can you go a level above and then?
I mean, it's most effective at the same level. Also, it gives it some diagnostic advantage because I can actually just, if the patient has persistent L5 pain, you put the patient on the table, say, are you feeling the pain right now? Yes. Put the needle in, put half a cc of lidocaine on the nerve root and say, do you still feel the pain? Usually they say it went away right there. It's replaced with some numbness, but at least the pain's gone. Then you just administer a little steroid.
Do you put it in the interlaminar space at L5S1, or you always go in the foramen, or when do you go interlaminar space? When do you do foramen?
It depends on the patient's pain complaints.
L5 radiculopathy.
Almost, if it's one-sided radiculopathy at a single level, always transferaminal. Just get it right on the nerve root because that's almost always where the irritation is. And with a transferaminal root, there's more more of the injectate spreads into the anterior epidural space. If they have any significant lateral recess stenosis or anything and you put it interlaminarly, all the medication just sitting in the posterior epidural space. It's somewhat effective, but I think transferaminal is much better.
Does it ever not go into the foramen? Does it ever go like into the into the retroperitoneum, or like lateral, or is it difficult to make the flow go into the foramen, or you always put your needle right in the foramen so you know it's...
Put the needle right into the foramen. You use a.
That's a really small space, though. Look at this. Look at this frame right here. I mean, how do you know you're not inside the nerve root itself?
The patient will tell you if you're inside the nerve root.
Okay, so what happens if the patient tells you? Then what do you do?
I mean, you can just. I mean, I don't use any sedation for my procedure, so just advance the needle. If the patient starts to feel paresthesia, I mean, you go really slow. If they feel some paresthesia, you just back the needle off. Usually, if you penetrate the nerve root sleeve, even if you're not inside the foramen all the way, if you penetrate the nerve root sleeve and administer contrast, you can see it spread medially. It'll go right into the epidural space.
Okay.
If you consider the size of the foramen is maybe like 5 millimeters or 7 millimeters.
Pretty small, though.
Yeah, you're only talking about a 22 gauge needle. It'll fit in regardless.
So what did you do? You did a laminectomy on this guy?
Hemilaminectomy.
Hemilaminectomy.
It was very, very difficult because the 5 root dives here, so it's really, really hard. I mean, obviously it's not technically very challenging, but it's hard because you do it through a small incision and like a tube, sort of.
Did you decompress the bone spur on the inside?
Everything. He's decompressed and he's pain free right now. But the question is, like, how long is it going to last? All right, that's it. Does anybody have any questions? Can you open the? Does anybody have any questions or comments?